We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 170, Retina Session 22. And this is the International Masterclass, and we have with us Professor Sandeep Grover, and he'll be talking on hereditary choroidal diseases. I request Dr. Ritesh Narula, sir, to please introduce him.
A very good evening to all of you, and a very warm welcome to Dr. Sandeep, Professor Sandeep Grover. It's really an honor for me to welcome you to this iFocus session, and we are really happy and glad that you could make it for this session, sir. To introduce Professor Sandeep, sir is a professor and associate chair at Department of Ophthalmology in University of Florida, and he has been a postgraduate from Rohtak Medical College and then subsequently from Chicago, USA. And he has done his lot of work in electrophysiology and medical retinal diseases and hereditary retinal diseases. So it's really an honor for us to listen to him today to talk about such an important and a tough topic for all the students on hereditary retinal degenerations. And welcome, sir, and looking forward to hear from you.
Thank you very much, Dr. Narula, for your kind words, and thank you, Dr. Honauer, for invitation and introducing me to iFocus. I did not know about this, and it's an amazing resource that you have built up, you and your team have built up, so that's very good. In fact, I've told my residents to look into it and listen to these lectures.
Thank you so much. In fact, just to give a background as to why Sandeep is here, because he wrote the same chapter in Stephen Rand. So we are choosing our international masterclass speakers by the chapters that they have written in Stephen Rand. So
I see. Well, I got lucky. I was with my mentor Jerry Fishman, who is well known and respected in the field of inherited diseases. So I got to write with him. So that was nice. Well, good evening, everyone, and let's get started with this a little bit of a dry topic, choroidal dystrophies. We'll see if we can keep it interesting so that you don't go to sleep. So I'm right now located, I'm in my clinic, I'm in my office. This is Jacksonville, this is the University of Florida campus. You see the Twin Towers here, and I'm on the second floor right at the corner here. You can see the ocean in the background. So we're about 15 minutes drive from the ocean. Beautiful place. And no financial disclosures. Well, yesterday was Lodi, today is Makar Sankranti, so very happy wishes to everyone. I know people are there from all over the country. So what we are going to talk today is about these choroidal dystrophies, which is a group of inherited chorioretinal diseases. And the few major things that are included in that is the primary choroidal dystrophies, choroideremia, gyrate atrophy of choroid and retina. And then there are certain conditions that mimic these choroidal dystrophies, and we'll talk about those as well. If you look at the primary choroidal dystrophies, there are another 4 kinds, like a subclassification of primary choroidal dystrophies. Basically, it depends upon the region of the choroidal dystrophy. So the central areolar choroidal dystrophy, peripapillary, diffuse, and the progressive bifocal chorioretinal atrophy, also PBCRA, that's how it is called. So those are the few things we will go through. Now, if you look at this, what is the central theme in this? Or I can make it easy. What is the central theme in this? Anyone?
Dr. Matangi, would like to answer that?
Socks, right?
Loss, yes.
Socks. So what
Yes,
is the theme? What is the theme here?
Here there's atrophy all around.
So you see all these atrophic areas in these 4 patients, they all look like gyrate atrophy, all the scalloped areas. So they look like gyrate atrophy, but all these 4 conditions are totally different. And that is why we're going to go through this talk trying to see how to dissect it out. So we'll start with the SOCs, the pediatrics one. It's interesting, these go by medical specialty. So just a couple of minutes introduction. So everyone knows about the eyeball. Everyone knows about the retina in the back, the 10 layers of the retina. I'm not going to ask you to name the layers. But what is important is this junction between the photoreceptors, the rods and the cones, the RPE and the choroid. This is a very, very important junction in the eye because they are interconnected to each other. They are dependent upon each other for their survival. So if there's a disease like retinitis pigmentosa that affects the photoreceptors and the photoreceptors degenerate, the corresponding area of the RPE and the choroid will also degenerate. And so, similarly, if there's a disease that affects the RPE and the RPE degenerates, sooner or later, the photoreceptors and the choroid next to it will also degenerate. So that's a very important junction and something important to keep in mind, because as we go through it, you will see how things are affected and what tests can be done to look at it. Choroidal dystrophy may be a misnomer because although it implies that the primary defect is in the choroid, but there is a lot of evidence that is coming up that a lot of these defects in choroidal dystrophies actually start in the RPE cells. And then subsequently, as we talked about it, both the RPE and the choroid, they atrophy. So as you know, there are tests that we do for structure of the retina. OCT, everyone knows about that. Fundus autofluorescence, which gives you an idea about the retinal pigment epithelial cells because of the lipofuscin in the RPE cells. So if the RPE cells degenerate, it leads to a hypoautofluorescence, and it's a great test sometimes to look for subtle defects. Fluorescein angiography tells you about the circulation, so about the choroidal circulation, about the retinal circulation, so partly about the structure. Then there are tests for retinal function. The visual acuity that we do every day on every patient, on every visit, tells you about the macular function mainly. The visual field, which again is a retinal function test, and then ERG and EOG. And before we go into the topic, just a brief thing on ERG. So mainly there are two kinds of ERG. There's a full field ERG and there's a multifocal ERG. And what is important to remember is that the multifocal ERG tests only the cones right in the macular area, so you don't have to dark adapt these patients. And it tells you only about the cone function or the macular function. Whereas the full field ERG, the important buzzword is diffuse. It is the responses from the photoreceptor cells and the other cells of the retina. It gives a diffuse response. So if there is a localized disease somewhere in the retina, the full field ERG may still be normal. So a large amount of the photoreceptor cells have to be affected in order to affect the full field ERG. Origin of ERG waveform, there is a negative deflection that, so when the light strikes the photoreceptor cells, the rods and cones take up the light, and that is what gives rise to a deflection, a negative deflection, which is the A wave. And then the electricity that is set up at the level of photoreceptors passes through the middle and the inner cells of the retina, the Mueller cells, the horizontal cells, bipolar cells, and that gives rise to a positive deflection, which is usually double the height of the A wave, and that is the B wave. So looking at the ERG, whether A wave is affected, B wave is affected, or both are affected, you can kind of localize the pathology. So again, just to tell you the waves, where it comes from. So when we do ERG, there are ICEV standards, and we dark adapt the patient for at least 30 minutes, hook them up with the instrument, flash a dim light that gives us the rod response or pure rod response. Then we stimulate the retina with a brighter flash, and that is rod predominant response. because of the intensity of light being bright, some of the cones get stimulated, but it's still rod predominant as it is dark adapted. Then we light adapt the patient for about 10 minutes and stimulate with a white flash, that is a cone response. And then we want to know what is the maximal cone response. So we stimulate with a flickering light, anywhere between 28 to 32 hertz. And these are the waveforms that we look at. So the dark adapted, pure rod, combined rod and cone, the cone response, and then the flickering response. And this is how the multifocal looks like, where there are individual ERGs in the macular area, and then that can be reconstructed in the form of a color map. And so it tells you about the sensitivity in the macular area. So this is the foveal peak, and obviously it's most sensitive in the fovea. And then as you go away from the fovea, the sensitivity goes down. That is how a normal multifocal would look like. That's someone getting the test done for a full field ERG. Okay, so let's go to that classification again, talking about the primary choroidal dystrophies, and we'll look at these one by one. So yeah, these are socks, but we cannot rule out stocking, slippers, lymphangiomatoses, recommend clinical correlation. Love this one for radiology people. So central areolar choroidal dystrophy, the first one among the primary choroidal dystrophies, was first described by Nettleship in 1884. It is primarily autosomal dominant inheritance, although autosomal recessive has been reported, but remember, autosomal dominant for central areolar. The genes identified are mainly in the peripherin RDS gene, which nowadays is called PRPH2 gene, and the autosomal recessive one has been identified in the GUCY2D gene. Initially, the symptoms, they start around the second to third decade of life. These are bilateral macular lesions, as the name implies, central choroidal dystrophy. Early on, you see the changes mainly in the RPE, like mottling of the retina, mottling of the RPE in the central area. And in the advanced stages, there is a lot of loss of RPE and choriocapillaris. You will notice that pretty much in all these choroidal dystrophies, the advanced stage is loss of RPE and loss of choriocapillaris. So you see the large, the intermediate and the large size choroidal vessels in most of these in the advanced stage. And it is very tough to try to figure out what the diagnosis is sometimes in an advanced state, because it's just diffuse choroidal dystrophy or degeneration. So coming back to central areolar, they have bilateral macular lesions that are well defined, and it does not extend into the peripapillary area or beyond the arcades usually. So if you notice, this is a kind of a well demarcated area. You can kind of see the sclera because of the degeneration of the RPE as well as the choriocapillaris, and you see these large choroidal vessels. And you see that it does not extend to the optic nerve. It does not extend to the vascular arcades. So if you think about that disease, and you can pretty much intuit what the test would look like. So the visual fields probably start with a central scotoma because they are macular. And there is a progressive increase of the central scotoma, but the peripheral fields should stay normal. Fluorescein angiography will show a window defect in the area of that macular atrophy, and will show hyperfluorescence in the macular area. ERG, remember again the full field ERG, because this is only affecting the macula and nowhere else in the retina. So the full field ERG may actually usually be normal. The multifocal ERG, however, will show the absence of foveal peak and decreased sensitivity all around, because that is testing the macular function. The EOG will be normal, and the OCT shows the loss of RPE and photoreceptors and choriocapillaris. In the advanced stage of central areolar choroidal dystrophy, which some of you must be thinking when you looked at the picture. It could be an end stage of Stargardt disease. It could be cone dystrophy that led to that kind of an atrophy. It could be pattern dystrophy. It could be age-related macular degeneration if the patient is older than 60, 65. Or it could be from the drug toxicity of thyroidazine. So history becomes important, and genetics becomes important. And most of the time you can tease out whether this is a central areolar choroidal dystrophy or one of these. Sometimes examining the family members that come with the patient is very helpful. As a rule, any inherited disease, not only choroidal dystrophy, but if I'm seeing any patient with any inherited retinal diseases, if there is a relative with the patient, I will take a quick look at the fundus, and many a times that gives me a clue to the diagnosis. To make that a habit. So that was about the central areolar choroidal dystrophy. Now going to the second one in the primary choroidal dystrophy is the peripapillary choroidal dystrophy. Now here the inheritance pattern is autosomal recessive. And again, although autosomal dominant has been described, but it is mainly autosomal recessive. The autosomal dominant that has been occasionally reported is also referred to as, you may have heard the term, helicoid peripapillary chorioretinal degeneration. But this one is mostly autosomal recessive. As the name implies, the atrophy is in the peripapillary area of RPE initially, but it can slowly progress out from the optic nerve and can involve the macular area when the vision gets affected. So you see this patient bilateral lesions. So that's the optic nerve there, and you see the atrophy around it, and it extends like pseudopods along the blood vessels, but it also extends to the macular area and affects the vision. That is another patient just showing similarly that this is the optic nerve, that's the peripapillary atrophy. The third one is the progressive bifocal chorioretinal atrophy, which was first described by Douglas in 1968. This is also inherited as autosomal dominant pattern, and the gene has been localized to the long arm of the chromosome 6. This is usually associated with nystagmus, myopia, and a higher incidence of retinal detachment. Now, as the name suggests, it's progressive. It is bifocal, which means that there are two foci of atrophy. So initially, there is a congenital macular lesion. That's the earliest change that you see. And that's the reason why these patients will have nystagmus, because this is from birth, that the macula had this lesion. And then later on in life, towards the first and second decade of life, that's where the nasal to the optic nerve, something starts, the atrophy starts. And then both the macular lesion and the nasal, so two foci, they expand. And when they expand, they leave a kind of a vertical area which is normal. So the retina, which is confluent with the optic nerve, you see a vertical band. That is the only normal area. The rest shows the atrophy. So those are the stages. And you can see in a patient here, this vertical band that looks normal. Rest is diffuse atrophy of the RPE and the choriocapillaris. You see the sclera actually underneath it. And then the last one among the primary choroidal dystrophies is the diffuse choroidal dystrophy. This one is autosomal dominant inheritance pattern. Again, I write down the other part, which can be autosomal recessive, because there are isolated reports of all these things. But you have to remember it's mainly autosomal dominant, this kind. The initial symptoms usually don't start till 4th to 5th decade of life. And the earliest changes are in the form of, again, RPE mottling and hypopigmentation. Usually starts around the posterior pole, around the macula. but later changes can affect the whole retina, all the RPE and the choriocapillaries, they atrophy. The larger choroidal vessels can be seen underlying. And one important distinction from retinitis pigmentosa like picture is that even though there is widespread dystrophy or atrophy of the RPE, the retinal vessels usually remain normal, even in the advanced stages. So this is someone who has diffuse choroidal dystrophy. Spares the center part maybe for some time, but sooner or later that is affected as well. So visual fields will show a progressive concentric peripheral constriction. The fluorescein angiography will again show loss of RPE and choriocapillaries, and we can see the larger choroidal vessels. And ERG initially will be subnormal, but as it becomes more diffuse and the photoreceptors are lost, it becomes non-detectable. So if you know the pathology of the disease, what is being affected, it's easy to tell what the test will be like. Of course, in advanced stages, any of these inherited diseases can lead to an advanced diffuse RPE atrophy and can look like diffuse choroidal dystrophy. Stargardt disease, cone dystrophy, pattern dystrophy. We'll look at some of these pictures later. And drug toxicity from thyroidazine. Remember the important syphilitic retinitis or choroidal retinochoroiditis can also look like that in advanced stages. Okay, of course, you look at pathology, these are clearly SOCs. So those four were the primary choroidal dystrophies. Now we go to the next one, which is the gyrate atrophy of choroidal retina. So this was first described by Jacobson in 1888, and he described it as atypical retinitis pigmentosa. But a decade later, Cutler and Fuchs, they described this first time as gyrate atrophy of choroidal retina. So this one has an autosomal recessive inheritance. The hallmark is that this condition is associated with high ornithine levels in the plasma. And the serum ornithine levels may be even 10 to 15 times the normal. And it is caused by the deficiency of the ornithine aminotransferase enzyme or the OAT enzyme. So ornithine is a non-essential amino acid that is an intermediate compound that is formed with the urea cycle, and it is formed from arginine. So arginine forms ornithine, which is converted into proline through the step which requires the OAT enzyme. And another important thing to remember is that the OAT enzyme also requires vitamin B6 as a cofactor, and that is why this becomes important for treatment, which we'll bring it up later. So again, genetics, it's autosomal recessive. The human OAT gene has been mapped to the long arm of chromosome 10. And in fact, there is an OAT deficient mouse model created, which has actually helped us to understand more about this disease. There is high activity of OAT not only in the retina, but also in the liver and kidneys. And the high ornithine levels are not only found in the plasma, but also in urine and aqueous humor and the CSF in these patients. Again, this usually starts around the second to third decade of life. And this is one of the night blinding disorders. So the early symptoms are in the form of problems with night vision, problems with peripheral or sight vision. And then later on, it can lead to progression of peripheral visual field defects. And then the central vision can be affected as well. So how does it look clinically? In the fundus, it begins in the mid-peripheral area, not in the central area, not in the extreme periphery, but in the mid-peripheral area. And typically, it has well demarcated and what is called the scalloped areas of RPE degeneration. where the choroidal vessels are visible in the area of degeneration, just like any other choroidal dystrophy, but these are very discrete and scalloped areas. And then slowly, these areas, they coalesce or come together to form a ring, or called a garland shape. So the peripheral or the mid-peripheral retina has these changes, whereas in more advanced stage, these atrophic changes, they progress peripherally as well as centrally. And so then in late stages, it can end up as a total atrophy of the choroid and the RPE exposing the white sclera, looking like diffuse choroidal dystrophy. So this is one of the pictures here, where just to orient you, that's the optic nerve, that's the macula is somewhere there. So you can see the mid-peripheral retina has these scalloped areas, well demarcated. These are coalesced together already. And you can see that intervening retina still looks good. And then slowly this progresses towards the macula. Some of the associated features with gyrate atrophy are high myopia. Posterior subcapsular cataracts are more common with this condition. Posterior subcapsular cataracts actually are common with a lot of inherited diseases like retinitis pigmentosa, cone dystrophy. So vitreous opacities can be seen, epiretinal membranes, just a higher incidence of those things, and cystoid macular edema in gyrate atrophy of choroid. The visual field, you can again think about it, since it is in the mid-peripheral area, these are first partial ring scotomas that coalesce to become a complete ring scotoma. And then these scotomas, they expand peripherally as well as centrally. So eventually there's a concentric field loss and they are left with a central field only. Fluorescein angiography will show the loss of RP and choriocapillaris in the scalloped areas where you can see the underlying choroidal vessels or the larger choroidal vessels. ERG in the early stages, remember it's a night blinding disorder, so the rod function is affected. Cones may be normal in the early stage, but as the atrophy extends, it becomes non-detectable. Both the rod and the cone responses become non-detectable in late stages. And EOG similarly follows the same way. Earlier on, the EOG may be very mildly reduced, but in late stages, they're markedly reduced. So EOG is tells you a function of the RPE cells. There are some systemic associations with gyrate atrophy, abnormal EMGs, abnormal EEG, abnormal electrocardiographic changes, and if a muscle biopsy shows atrophic type 2 muscle fibers with tubular aggregates visible on electron microscopy. So there are some systemic associations with this. Differential for gyrate atrophy, there's been reported a few cases of gyrate atrophy-like fundus. So they show the gyrate atrophy-like changes on the fundus, but the ornithine levels are normal. Whereas in gyrate atrophy of choroid, the ornithine levels should be increased. So the gyrate atrophy-like fundus with normal ornithine levels is actually autosomal dominant, as opposed to gyrate atrophy with increased ornithine levels, which is autosomal recessive. It should also be differentiated from choroideremia, because, and you will see later, I'll show you a picture where in the early stages, it may show those scalloped areas of RPE and choroidal atrophy. Looks just like gyrate atrophy, but it's an early stage of choroideremia, sometimes can look like that. And when the gyrate atrophy is advanced and the choroideremia is advanced, they can look similarly. So family history there becomes helpful because choroideremia is X-linked, whereas we said before gyrate atrophy is autosomal recessive. It should also be differentiated from retinitis pigmentosa because again, in extensive atrophy, RP and gyrate atrophy can look alike. Important differentiating feature is in the gyrate atrophy, you get pigment clumping, whereas in retinitis pigmentosa, the hallmark is monospicule pigments. So that differentiates the two to some extent. And of course, the retinal vessels are attenuated in retinitis pigmentosa pretty early on. So those become the distinguishing feature, how you distinguish retinitis pigmentosa from gyrate atrophy. So in gyrate atrophy, where is the primary problem? Is it the choroid or the RPE? So the mouse model was very helpful, where histopathologic studies have been done in that ornithine deficient mouse model. And what it showed was that the earliest change started in the RPE cells, that there was a patchy degeneration of the RPE cells, which becomes more diffuse in about 6 months of that mouse model. And then in about 10 months is when the photoreceptors were found to be affected. So as I said before, that choroidal atrophies in general may be a misnomer, because some of these things have been known to start from RPE and not primarily from the choroid. Treatment for gyrate atrophy, and that's one of the reasons why we need to differentiate these different kind of choroidal atrophies, because if you miss the diagnosis of gyrate atrophy, you could have missed the treatment. Although the treatment is controversial, it's not set in stone that if you treat them, they become better. But it makes logical sense that if the high ornithine level is because the enzyme is not working, can we cut down the ornithine levels by restricting arginine? It makes sense. And that's why when you have someone with gyrate atrophy, you try to eliminate arginine from the diet. And the second thing was, remember, the use of vitamin B6 as a cofactor for OAT enzyme. So it has been shown that high dose of vitamin B6 given in these patients can reduce the ornithine levels in some of the patients. So if it does reduce the ornithine levels in some patients, they are called B6 responders. In others, where it does not affect it, they are called B6 non-responders. So that's the treatment that has been tried in gyrate atrophy. And there have been, I mean, it's tough to really conclusively say that that will help, because first of all, there are not too many patients with gyrate atrophy floating around. So you can't take like 50 patients and eliminate arginine and 50 patients and don't eliminate arginine and compare the two. So it's tough to find so many patients. And that's the reason why there will never be a conclusive evidence for that. So you go by logical sense. Okay, so that was about the gyrate atrophy of choroid and retina. Next, we move to choroideremia. So choroideremia was first described by Martner in 1872. The inheritance pattern in choroideremia is X-linked recessive. And basically, it's a bilateral progressive degeneration of the choroid and retina. And this is also one of the night blinding disorders. So this, you can usually start seeing changes in the first decade of life, most of the time. And definitely by the second decade of life, definitely by teenage years, but usually even before age 10. And it starts off as a delayed dark adaptation, meaning problem adapting to the dark when they come from a lighted area. And one of the questions I asked is a movie theater, that if you go to a movie theater, I can just walk to my chair after coming from a lighted area to a dark theater. But the people who have night blinding disorders, whether it is choroideremia or retinitis pigmentosa, they have to stand there or get help in order to get to their seats because the dark adaptation is delayed. And then as the disease progresses, it leads to a night blindness or nyctalopia. There is also progressive field loss, and the field loss is a concentric field loss till a central field is left. And the central vision is retained till late in life, usually till about age 50 or so, even later. The vision may be 20/20, although their visual fields may be reduced to less than 20 degrees, and have tubular vision, but the vision is 20/20 most of the time. So here you see these early changes in choroideremia that starts off as a salt and pepper mottling, but they can also develop these gyrate or scalloped lesions like gyrate atrophy. But this patient had choroideremia because, how do we know? So that is the grandfather of this patient, maternal grandfather, because it's X-linked. So this has to come from mom. The mom was the carrier. And grandfather, you can see typical choroideremia picture where there is diffuse chorioretinal degeneration. There is maybe some pigment clumping. Again, you don't see bone spicule pigments usually. And what is important in choroideremia is that for a long time, it spares the macula and it spares the peripapillary area. And so that's the normal retina, that's the normal retina around the optic nerve. But of course, in later stages of life, that can go away too. So visual fields, they show progressive concentric visual field loss, only a central island later in life, and that can be wiped off too. Fundus autofluorescence shows areas of RPE loss, the lipofuscin loss. And again, like so many other conditions, it's a good tool to monitor the progression of the condition. ERG in early stages, both rod and cone responses are reduced, just like retinitis pigmentosa. And in the later stages, they are not detectable. And in OCT, of course, it shows the changes around the macula. And CME has been described, which can be treated with topical dorzolamide. We reported a study where using topical dorzolamide is helpful in some patients. It doesn't affect everyone, doesn't help everyone, but some patients. That's an OCT, so normal appearing macula, and there's atrophy all around. So you see the normal area here, the normal retina, some RPE, the photoreceptors too, and the choroid. But as you go out from the foveal area, you see thinning of the retina, atrophy of the RPE, atrophy of the photoreceptors, and atrophy of the choriocapillaris and intermediate layer of the choroid. So that's what the OCT will show. As we talked about it, it's the inheritance pattern in choroideremia is X-linked recessive. The gene defect is localized to the X chromosome at that location. The choroideremia gene encodes for the RAP-SQUAT protein, the RAP1 protein, which is one of the two subunits of RAP, geranyl transferase. And these RAP proteins, they regulate the intracellular vesicular transport, and that's where the problems happen. Treatment, at least in choroideremia, the treatment is further ahead, where there have been a few phase 1, phase 2 trials that have been done for gene therapy with a viral vector. And they have established that it is safe, and it does provide some stabilization of visual acuity. So there were, I think, 6 patients in one study and 6 in another study. And majority of them, the visual acuity, the progression of visual acuity slowed down. And there was some improvement in isolated cases. And there are other phase 1-2 trials and even a phase 3 trial being now conducted or planned in USA, Canada, and UK. And then people are also looking at stem cell therapy for choroideremia. Now, when we talk about choroideremia, because it is X-linked and the carriers are the females, so the mom would be a carrier of choroideremia of affected male, and then all daughters would be carriers as well. So there are certain findings that are characteristic of carriers of choroideremia, although they show variable findings. Some of them show very subtle findings, and some of them show pretty much as much as sometimes a male. But usually the changes are milder. And a lot of times it can be asymmetrical between the two eyes. The typical change that is described is like a moth-eaten appearance of retinal mottling. It is it is a lot better seen in autofluorescence. I'll show you in a moment. And the pigmentary changes are in the form of radial bands that you see in the mid-peripheral retina. Pretty much either there's a mild effect or no effect on the visual fields and ERG. So this is another carrier where you can see these bands, and in the fundus autofluorescence, again, you can see those pigmented bands, but you can see the moth-eaten appearance in the mid-peripheral area. So that was about the primary choroidal dystrophies, the choroideremia, gyrate atrophy of choroid and retina. Now, lastly, we come to the phenotypes. There are certain conditions that resemble one of these choroidal dystrophies. So it's important to know those conditions too. So we kind of touched upon some of them. X-linked retinitis pigmentosa, which is the most severe form of RP. And again, it's a night blinding disorder with a progressive loss of visual fields, progressive loss of ERG. The mutations have been mainly described in what is called the RPGR gene. So here you see a late stage of X-linked retinitis pigmentosa with the fluorescein angiogram of the same patient. So you see a widespread atrophy of RPE and the choriocapillaris. And it's tough to differentiate that from, let's say, a choroideremia patient or even diffuse choroidal atrophy patient. So that comes in the differential. Kern-Sayre syndrome, again, important that we need to diagnose this condition. It's a multi-system mitochondrial DNA deletion syndrome where you see pigmentary retinopathy, you see progressive external ophthalmoplegia, and ptosis. So if you see someone with pigmentary retinopathy and ptosis to begin with, always think about Kern-Sayre syndrome. Initially, that pigmentary retinopathy is mild, but can progress to severe chorioretinal degeneration. Why is it important to diagnose Kern-Sayre syndrome? Because there are some systemic issues with it, and the most important systemic issue is the presence of cardiac conduction block. So you need to diagnose this condition and send the patient to a cardiologist to monitor for cardiac blocks for the rest of their lives. There have been people who have lost their lives because they were not diagnosed as Kern-Sayre syndrome, so they did not get help. So other systemic issues that go along with it is cardiac conduction block, cerebellar ataxia, there's a high CSF protein concentration, and muscle biopsy can show ragged red fibers, which goes along with the mitochondrial syndrome. So here is a patient with Kern-Sayre syndrome who had ptosis and ophthalmoplegia, and you can see a mild case where there was a mottling, kind of a generalized mottling all over the retina. But this is again an advanced case of Kern-Sayre syndrome where it shows a diffuse atrophy of RPE and choriocapillaris, and you can see the larger choroidal vessels, kind of the same theme. And so that can be confused with, for example, primary choroidal dystrophies. But look for ptosis, look for ophthalmoplegia in these patients. Then you have the BADs, crystalline dystrophy. Most often you diagnose this in the third decade of life. There is retinal degeneration. There is glistening crystalline lesions in the posterior pole in the macular area. And about 1/3 of these patients will have crystals in the paralimbal region of cornea as well. And these crystals are nothing but cholesterol esters. There is a localized and a diffuse form, and ERG parallels the retinal degeneration. If it is localized, the ERG may be normal, the full field ERG may be normal. And if it is a diffuse form, the full field ERG is non-detectable. BADs as autosomal recessive, and the mutations have been described in the CYP4V2 gene. So you see here again, choroidal kind of dystrophy with loss of choriocapillaris, RPE, you see the larger choroidal vessels, and you see these glistening white spots and crystals. And on a slit lamp in the cornea also you see these crystals. Then you have toxicity from thyroidazine. And thyroidazine is a medication that has been used for treatment of psychosis since 1959. Initially, when it started being used, it was used in very high doses. And that's where the toxicity was seen. So again, you can see early on, it starts off what is looked as scalloped areas, and it can look like gyrate atrophy. But later on, there's a diffuse dystrophy or diffuse loss of RPE and choriocapillaris, and it can look like any other choroidal dystrophy. So think about toxicity from the medication. Again, this angiogram just shows the loss of RPE. So once this was recognized about the toxicity, the dosage, the clinical dose was cut down a lot, and we hardly see thyroidazine toxicity now from the clinical doses that are used. Stargardt disease usually starts by this in the first decade or second decade of life. This is the most common juvenile onset macular dystrophy. Typically, what has been described is a beaten bronze appearance in the macula with flecks around it. So if you just look at this macular lesion with loss of RPE, choriocapillaris, some sclera showing through the large choroidal vessels, there is some pigment clumping, well-demarcated lesions, not involving the optic nerve, that reminds you of the central areolar choroidal dystrophy. But what is different is the presence of flecks. And sometimes there are not enough flecks. There may be just a few flecks around it. So if you see flecks around a central macular lesion like this, that's Stargardt disease until unless proven otherwise. So look at the flecks, and if you see it, then it's most probably Stargardt disease. Otherwise, it can be confused with the CACT. So this is a patient, actually, I found out about the gene mutation on Monday. So I put that in. A very interesting family, actually, who the prototype, the first patient that I saw was this patient who was 57 at that time, almost 10 years back. And she showed a diffuse choroidal and retinal degeneration. She was like count fingers in both the eyes. And you can again see these kind of scalloped areas in the mid-peripheral area, but you can see the posterior pole is, it's all atrophic. That's why the vision is down. And you can see that very well on the fundus autofluorescence as well. And she had a nephew and a niece, her sister's son and daughter, who had typical lesions of North Carolina macular dystrophy. So I was like, and the sister did not show much except bruising. And her vision was 20/20. So I thought maybe this is North Carolina macular dystrophy, which is because North Carolina macular dystrophy is autosomal dominant. So I felt that it could be that in later stages of North Carolina macular dystrophy, you can get this kind of degeneration. But when I initially saw her, I said it's probably Stargardt disease or cone dystrophy, and the ERG was non-detectable. So finally, we got the gene testing done after a lot of convincing. So the results came back Monday, and she actually has the ABCA4 gene mutations, which kind of points towards Stargardt disease or cone dystrophy or similar. And the niece and nephew that we tested, they had the gene mutation for North Carolina macular dystrophy. So it's an interesting family, I think, where the North Carolina macular dystrophy gene probably came from their dad. And dad is not living, and so I cannot get them tested or their side of the family. But I think that came from that side. And this has got nothing to do with the nodular macular dystrophy. So it's an interesting family where two rare diseases exist in the same family. But the point was that you can see these scalloped areas in this Stargardt disease, advanced stage of Stargardt disease as well. And then you have pattern dystrophy, which is autosomal dominant. It shows mild RPE changes like butterfly-like lesions that have been described. And usually they have a good prognosis. The vision stays good, fields stay good till about the 5th decade of life. And some of them actually can live their lifetime without affecting the vision too much or not at all. But they can progress sometimes to diffuse degeneration of choroidal retina, especially in the macular area, and sometimes a diffuse degeneration. Okay, so these are the things that we went through. We said the choroidal dystrophies are divided into primary choroidal dystrophies, choroideremia, gyrate atrophy, and some of the other kinds that resemble one of these types. And the primary choroidal dystrophies are these kinds. So another way to look at it for classification is you can kind of break them into generalized and regional choroidal dystrophies. So you can, the central areolar, peripapillary, and progressive bifocal are kind of regional choroidal dystrophies, although they can progress to be diffuse, but initially they are regional. Whereas the diffuse choroidal dystrophy, choroideremia, and gyrate atrophy are more generalized choroidal dystrophies. So we come back to these 4 pictures that we started with, and now that you see that these were 4 different conditions, and not all of them were gyrate atrophy, but they can look like gyrate atrophy. And so the point is that just looking at a picture sometimes a lot of times it's not diagnostic. You got to depend upon a good history, a good family history, try to see whether it is autosomal recessive, autosomal dominant, or X-linked. Try to examine other family members. Sometimes testing like ornithine levels or something like that can help. Of course, gene testing nowadays is very helpful, and it's much easier to do gene testing now than it was 5 years back or 10 years back. And so we can learn a lot from these things and why it is important to diagnose these things. So we kept this at the end for our ophthalmology. Thank you very much. And any questions are welcome. My email address is there. Please feel free to email me with any questions that you may have later on. Thank you. Thanks again for inviting me. It was a privilege.
Thank you so much, sir, for the wonderful lecture. Dr. Dinesh Talwar, sir, would like to say some words.
I think
How are you, Dinesh?
Hi, how are you?
Good, good.
It's really wonderful hearing you, and you made something so complex look so simple. I had 1 or 2 questions which I, had in mind. You showed one patient with gyrate, and then there was, I think, if you have to differentiate that from a choroideremia. Now,
the one with gyrate atrophy?
The one who had a grandfather who had a more severe form of the choroideremia. The grandfather had very severe choroideremia, and
yes.
Now, supposing the grandfather was not there,
yes,
then how would you make the differentiation between a choroideremia?
This one, right?
Yes.
Yeah, that's always a problem. Although in choroideremia, a lot of times you can look at the mom and look at the daughter. That can sometimes be helpful to look for a carrier stage. Because if it is gyrate atrophy, the mom and the daughters won't be affected. You won't see anything in the retina. But sometimes you're stuck when you don't have other family members, and that is the only person that you are seeing. And I leave them saying that this could be this or this could be that. And it could be very well gyrate atrophy of the choroid, or it could be choroideremia. And then keep following them with another 5-10 years, it kind of you can kind of get an understanding of where it is headed.
So then would you get the ornithine levels and everything done before you reach that?
Yes, I would, yes.
So even if so wherever you're not sure, you'd have to get this done to separate the two out.
Absolutely, yes. If you suspect gyrate atrophy and you're not sure, I get the ornithine levels. It's such a simple thing to do.
Yeah.
But again, then the confusion becomes you can have gyrate atrophy with normal ornithine levels. Medicine is funny. It's interesting. That's what makes it interesting, that every patient doesn't follow the book.
Yeah. So tell me something. Doesn't it look like the gyrate atrophy ones had almost bare sclera visible with even the main choroidal vessels not being there? Whereas, say, for example, see the gyrate atrophy, even the main choroidal vessels sort of are not there,
Correct.
But whereas in say the central areolar, you still have the the major vessels there, so that gives you an idea that this is different from that is. Can you use that, the degree of presence of the major choroidal vessels?
You can, and if you're seeing them at an earlier stage. But if you're seeing them at a later stage, it's so tough to differentiate them. In fact, I have patients who have followed for 15 years here in Jacksonville, and someone who started with pattern dystrophy actually, and the vision was good, and then develops choroidal neovascularization in the macular area in one of the scars in both the eyes, and sequentially, and then it scarred down. So now when he comes, he's now 62 years old, I think. And he has a scar which looks like age-related macular degeneration. So I tell the residents the same thing, that look, had I not seen him 10, 12 years back, I would have diagnosed that as age-related macular degeneration if he came to me on that day. So that is the reason why a good history is very important. And if you can get some pictures from the previous doctor that they have seen or whatever, that really becomes very helpful. And something that when I ask them, how long has this been going on? So if it's a 60-year-old person who says it's been going on for 15, 20 years, someone pointed it out, but my vision was good, that points towards some kind of a dystrophy or juvenile onset macular dystrophy rather than age-related macular dystrophies.
I think so. That's a very important point, that it's a sequential follow-up that sometimes helps you to reach a diagnosis, sometimes in retrospect rather than always prospectively. In the earliest changes, they could be non-specific. And in fact, the latest changes also could be different, non-differentiable from other such conditions.
Absolutely.
So it's only when you have the sequence over time that you see that, look, this is the pattern which is developing. So right. I think that's very important. I mean, actually the general impression that comes to postgraduates is ki main picture dekhunga and I will be able to diagnose. So it's not that simple.
Yeah. So actually, in a typical day, in my other retina clinics, I see about 40 patients in a day, so 20 patients in half a day. But my inherited diseases clinic, I see only 5 patients in half a day.
Okay.
And I see inherited disease only Monday mornings. So 5 patients, and believe it or not, even those 5 patients, I can usually not finish till 1 p.m. because there is so much to do, so much testing to do, so much to talk to these patients, talk about the gene therapies, talk about that. So it is really an interesting field, which I did not know of till I was in India also. Even in USA, unless you work in that field, it's very tough to get an understanding of that.
Yeah. So thank you very much. Anybody has any questions? And do you have any questions, Monica?
Yes, so there are a few questions from the social portals.
Yes.
So one question is that how would you differentiate between the retinitis pigmentosa and early stage of choroideremia?
So as I pointed out, that you usually do not see bone spicule pigments in choroideremia, whereas the bone spicule pigments are a hallmark of retinitis pigmentosa. The second thing is, if you are doubtful about retinitis pigmentosa, always look for cells in the vitreous. This is something that is missed a lot of times. So look for pigment cells in the vitreous. Invariably with retinitis pigmentosa, you will have pigmented cells in the vitreous, whereas with choroideremia, you usually won't see that. And the third thing is the attenuation of the blood vessels. That happens more with retinitis pigmentosa. In choroideremia, that does not happen till later on.
Right, sir. And so another question is that, like, what is the maximum visual acuity that we expect in these patients?
In which patients?
In patients with hereditary choroidal diseases in general.
So again, the visual acuity will depend upon the status of the macula. So if you're dealing with macular dystrophies like Stargardt disease, cone dystrophy, central areolar, they will behave like age-related macular degeneration. The macula is affected, the vision will be down. Most of the time, if the lesion is just in the macular area, they can plateau out at 660 or 2400 vision. Usually they don't progress beyond that unless the macular lesion progresses beyond the arc gates. And if in conditions like choroideremia, retinitis pigmentosa, where the macula is not affected initially at least, the vision can be totally normal. Pattern dystrophy, the vision can be normal. So the visual acuity totally depends upon the state of the fovea or the macula at a given stage.
Right, sir. So the last question would be that what is senile choroidal sclerosis?
Well, there are so many terms that you will find in medicine. Basically, choroidal dystrophy that happens with age. You call it senile choroidal sclerosis. But it's very hard to differentiate those things which have been just like described as isolated reports from other conditions.
Right, sir. Thank you for taking all our questions, sir, and thank you for covering this interesting topic. And
thank you, Dr. Sandeep. I think you made a very difficult topic very simple and in a very and in a point-wise manner. You actually led the all the delegates over here through the entire gamut of these changes. I think it was a wonderful learning process, and I think medicine is something that's a continuous learning thing. I think I learned a lot of things today, and as you said, inherited diseases, hereditary disorders are something which tend to get the short end of the stick unless you really get involved with them, and you really helped us to focus on them today. Thank you very much, Sandeep.
Thank you very much, Dinesh. It was nice to see you. Santosh, it was nice to see you. Thanks again so for inviting me, and good night to everyone.
Thank you.
Have a good day to you, sir. And next, our session will be on January 19th. That will be on abnormalities of cone and rod function by Dr. Tapas Bari. We'll all see you there, and hoping to have more hot seaters online.
Thank you.
Thank you, everyone.
Thank you, everyone.